Hi, good afternoon, everyone. Welcome to today's Health Equity event series, our third event in our Health Equity Initiative in partnership with the Health Policy Commission. I'm so grateful that you're here. Glad that you've been able to attend, and for the panel, the presentations and the discussions we have scheduled today. Before we get started, I want to thank Vivian and Kelly and the team at HPC for all their help designing this series and helping organize these talks, and for all of their support and guidance and organizing the work we're doing together and with many of you. So thank you to HPC. As I mentioned, today's event is our third in our health equity series focused on identifying and relieving the disparities in access and outcomes to healthcare. And today we have four entrepreneurs, each working to design products and optimize the experience for users that often suffer the greatest inequities, including people of color, those living with disabilities, and other marginalized populations. So today you'll hear from four owners, as I said, and entrepreneurs, each working in a different space, making meaningful and great impact for the populations that they serve. So first, before we get into the first speaker, let me just say we'll be taking questions in the Q&A that'll be managed here. So feel free to drop them in the chat. Each speaker will have about 4 to 5 minutes in presentations, and then we'll move to a Q&A that I'll moderate. So we're ready to get started now, and Anastasia will be our first to present. Thank you. With Four Blind.
Thank you. Hello, good afternoon, everyone. So thank you, first of all, thank you very much for having our company as one of presenters of this great panel, because it's a wonderful opportunity to share our values of accessibility and inclusivity, and also to tell how our company contribute to the development of our society, where every person have equal access to basic things. And I will start with introduction of our startup and tell about challenges of those people who we work for, and of course about solutions by which we're trying to solve problems they face. So For Blind creates technical solutions with the aim to help in expanding capabilities of blind and deafblind communities and eliminating barriers they face in communication, education, employment, and just independent life. So can you please switch the slide? Thank you. So let's start with some facts. According to the World Health Organization, there are more than 7 million people in the world who cannot see, cannot hear, and cannot speak. So next slide, please. And the only possible way for them to talk to other people is through the sign language with the help of interpreter. So it's a special person who always need to accompany the deafblind person to facilitate the communication with other people. We usually don't think about this, but some things that we all accustomed and used to are not accessible for them. For example, to have a private talk to a doctor. Next slide, please. And trying to change this unfair situation, we created a special communicator for deafblind people, which allows them to speak in a synthesized voice and to hear other people. So if you want to talk to the deafblind person, you just need to start speaking, and the special program will recognize your words and transmit exactly what you said by tactile signals to the main 6 keys. In order to answer, the deafblind person, you just type the message using the same 6 keys, and the special program instantly convert it to a synthesized voice. So it's pretty easy. Next slide, please. Other problem is one which blind people face in their everyday life. They cannot study any pictures only if it wasn't prior printed on a special printer. And of course, it is a barrier for them to have an access to this kind of information, visual information, a big share of which we get in our life every day. Next slide, please. So by that reason, we created our other solution. It's a Braille Pad, which is like iPad, but tactile and allows blind people to review any kind of pictures, even to take instant shots and then review these shots. So with that device, blind people can see the same pictures as we do, but in tactile way. And this device actually bring education, professional and social life of blind person to the new level because it provides inclusive access to the visual world. Next slide, please. So up to date, we have 3 people who already use Perkins communicator device, and we also got 32 pre-orders for the device, and now we are in process of production of the first batch of Perkins communicators. And recently we showed Perkins communicator and Braille Pad at CSUN, which is one of the major assistive technology conference and exhibition, and which is fantastic. We've recently got a great partner, Massachusetts Commission for the Blind, who is our champion in MassChallenge program. They facilitate introduction of Perkins communicator to the Massachusetts healthcare ecosystem. And for blind is a member of American Assistive Technology Industry Association. And over the last year, we became finalists for such wonderful contests like WISH, Qatar ENT Innovation Award, Great Britain, and Asian Entrepreneur Award, Japan. So next slide, please. And in the final, I would like to articulate our main values we share in our company. First of all, our work aimed to stop our society to talk about disabilities, but to talk about additional needs. So we strive to provide blind and deafblind communities with accessibility to services and things that we all have and use. With For Blind's innovative technologies, these categories of people get unique opportunities for access to such important things like getting an education, mastering new professions, and other social needs. So we are fully open for cooperation, and we are searching for partners, advisors, investors, and people who are ready to help us to change our society. And if you are that person or have any questions, please contact us by email or phone. Thank you for the attention. Sorry, I can hear you. Haven't I can hear you.
Sorry, that's bound to happen at least once more. So I'm sorry, my apologies. Congratulations on the new business and the pre-orders. That's incredibly exciting as you're growing. So good. Can you share a little bit about how you got involved focusing on blind and deafblind equity, and describe health equity for us?
Yeah, actually, we have our company for 3 years, and we do this for 3 years, and it wasn't like a personal story or something like that. Mm-hmm. Just the CEO of the company, he actually got know about unfair situation that deafblind people, they have only way to communicate with other people is just through the sign language, and also through a very, very expensive device. And he just decided to create something which would be cheaper, would be more convenient, and the person just can take this device with themselves and go outside and talk to other people, to talk to doctors, and that's why. So that's why we just started this, because we decided to change the situation, which looked very unfair. Because these categories of people, they actually get very unfair share of attention and assistance and things like that. And so we're trying our best in changing the situation.
That's excellent. And I'm sure, there are plenty of other, it seems to me that it shouldn't be as long a time coming, that this technology should have existed, and that it's, indicative really of the inequity that we're talking about now. So yeah, not having the investment, I can see that saying, it makes clear business sense. Can you talk a little bit about your partnership with MCB in government, and how that's, whether or not it has opened up additional pathways for you, and whether partnering with government has been as you'd expect?
Yeah, sure. So we we started our partnership like about 6 months ago, and during this time we actually got some great impact. I mean, we created we produced like 7 devices for them, because they actually one of the important organization in Massachusetts, which provide services for blind and also deaf-blind people, which is actually very rare. And so we prepared our devices for them, and we're going to ship these devices to MCB in I guess in last month. And we will see how it's going to work, and we would be very happy if our devices will be embodied in the healthcare ecosystem in Massachusetts.
Excellent. Yeah, congratulations on the progress so far, and thanks so much for joining and presenting today. Wish you the best.
Thank you very much.
And next, Rodney Bell is presenting on behalf of Butterfly Health. Rodney, we'll jump right in. Thank you.
Hi, I'm Rodney Bell. I am the co-founder and chief operating officer of Butterfly Health. And as such, next slide, please. The quote there, to whom much is given, much is expected, is very important to us. Butterfly Health was founded by myself and my co-founder, who's actually my sister. So the photograph you're seeing is of me and my sister as children growing up in St. Louis, Missouri. And the woman next to us is our grandmother who raised us. She was a woman who was a recipient of Medicaid and all other sorts of government-based services. So we understand fully the community we seek to serve, because we are part of that community. Next slide, please. What Butterfly Health does, and who we are, is we are the first of its kind that we have found that provides trauma-informed, strength-based behavioral healthcare applications for underserved populations. And when we talk about underserved populations, we primarily talk about Medicaid populations and populations that heretofore have been left out of the healthcare system as we know it today. Next slide, please. This is our founding team. Again, Ariva's my sister. I'm Rodney. Dr. Shabra is our chief medical officer. Justin's our technology officer, our CTO. What's interesting here is every person on this slide came from very humble beginnings, meaning all of our parents were part of a Medicaid, Medi-Cal being California, system. And all of us have gone on to do some interesting things. So on this slide, you see 2 Harvard graduates, 1 Columbia graduate, and 1 Stanford graduate. And that just shows you from humble beginnings, anything is possible. Next slide, please. So you talk about current events and what's happening in the country today. There's a large problem in this country. A, we've been hit by a pandemic. B, we've seen all the unrest associated with social unrest from George Floyd, and then the most recent events that happened in the same city, the same state, with this young man being shot again by police officers. All of these things combine to just make stress and behavioral healthcare needs just more prevalent and more prominent in today's society than they ever were. So the time now for us to address some of these needs and to provide an intervention to help young people particularly address some of their behavioral health concerns is more important than ever before. Next slide, please. It's a fact that 1 in 4 Americans suffer from some mental health condition, be it mild depression, mild anxiety, or the like. And COVID, the slide says, is expected to cause a global tsunami. Well, it has. The number of people who've expressed desire and needs to have healthcare issues dealt with has grown tremendously. The population that we first sought to serve when we started Butterfly was 70 million Medicaid recipients. That number is now 90 million people who are in fact Medicaid recipients who are in need of behavioral health services. Next slide, please. The current healthcare system in America is very fragmented, and it needs to be consolidated, but it's not. There's a shortage of providers. It's estimated by the year 2028, there'll be 40% less psychiatrists and social workers available to meet the needs of behavioral health concerns of the population. More importantly, the number of people seeking those services is due to increase tremendously. And there's a lack of access, and there's a stigma associated with that access. Next slide, please. The cost of Medicaid is about $131 billion, huge marketplace, huge opportunity for Butterfly, and that's a population we seek to serve. And that's where our primary focus is. Next, please. Our core values, basically, is pretty straightforward. We're culturally centered. We deal with intersectionality. We deal with non-judgmental care delivery. We take all of the identities of all the people on the platform into consideration and how they interact to create a whole person. So unlike lots of other applications, we take into effect the holistic person, the totality of the person itself. Next, please. The application is pretty straightforward. It's a 4-step process. We start with peer grouping support. We introduce our members to our platform, and we place them with condition-specific peer groups so they can talk with people who have similar concerns as they have. Then we go from there, step 2 is where we have our empowerment kit, which is basically an evidence-based CBT, DBT, ACT self-directed toolkit. Next slide, please. The third step on the journey with Butterfly is you have trauma-informed coaching. So we connect you with a coach where you have synchronous-based coaching available 24 hours a day, 7 days a week. So you can talk with a certified coach about problems that you may be having or difficulties that may be in your life currently. And then we mood map that. Basically, every day we send you a push notification to ask how you're feeling. And that gives us some indication of basically how you're progressing with the app and what we need to do to help you be a more well person. Next slide, please. And this slide may or may not be important. Ours is just a B2B model where we make our service available free to all of our patients. We charge hospitals and we charge insurance payers who are actually Medicaid payers to provide the service to their patients. Next slide. So we're different than the crowd. We don't do a lot of stuff with like listening to raindrops or all that fun stuff to help you sleep. That's not what we do. We provide you with services that we think make sense for you as an individual. We primarily focus on teens and adolescents, and we meet them where they live on their phones, and it's predominantly text-based. Next slide, please. Why Butterfly? Right founders, right solution, right time. Children are in need. Young people are in need of lots of support, lots of help. The world's moving very fast, a lot faster than it used to. Hence, we're here. Next slide. And that's us. We're Butterfly Health, and we invite everyone who believes in health equity to participate with us on our journey. I'm Rodney Bell, and thank you for your time.
Thank you, Rodney. Thanks for presenting today. Couple questions.
Yep.
Can you talk about how you got involved in the space? And then I know in discussions earlier, you made a distinction between health equity and intersectionality. Could you talk more about how you define intersectionality?
Yeah, well, intersectionality is not a clinical term. We define it as an analytical framework for understanding how aspects of a person's social and political identities combine to create different modes of both privilege and discrimination. Examples could be gender, caste, sex, race, social economic status, sexuality, gender identification, religion, physical disability, as the first presenter just talked about being blind, or physical appearance. So intersectionality identifies multiple factors, both advantage and disadvantage. And we think that these intersecting and overlapping identities are important to address. So as we talk about the Butterfly application, we try to holistically address the whole person without categorizing people into boxes of 30-year-old white men or 25-year-old Black women. We understand that there's much more to a person than those general boxes.
Sure. And in working with providers and insurers, and specifically on around with Medicaid populations, how are you first identifying the right individuals to work with? And then what are some of the competing priorities for providers and insurers that you're helping them solve?
Well, let's be clear, we work primarily with payers, i.e. insurance payers. We do spend some time with providers. So the value proposition makes much better sense for insurance payers from a Medicaid standpoint, to the extent we position Butterfly as an intervention to traditional one-on-one therapy. So to the extent that we can onboard one of their Medicaid recipients to the platform and take them through steps 1, 2, and 3 of the platform before they get to the need to have actual therapy, there's a huge economic benefit to the actual Medicaid payer to use our services. On the provider side, what happens is that they end up with lots of people in ER rooms and the like who are there because they're stressed or they're anxious, and they really don't need medical care. They need behavioral health services. And they end up seeing an ER doc that's costing the hospital a fortune. If we can avoid that and help them offset some of that and onto our platform, there's a huge cost savings for the actual healthcare system itself.
Thank you. And I think we have one more question. How are you engaging Medicaid members? Are you working?
Sure. Yeah, we do that through the actual plan. Like we work with the Blues, for example. We work here in Los Angeles with LA Care. LA Care being the largest provider of Medicaid services in California, for the record. So we work with the plans themselves to identify their patient population, and then we co-market with the plans to do outreach to their plan members.
Awesome. Thank you, Rodney.
You're welcome. Thank you.
Okay, next we have Shrenik John and Marigold Health. Thank you.
Hey everyone, great to be here. Excited to tell you all a bit about our work. I started Marigold actually after working as an EMT, and I actually left my undergrad to start this company. So pretty young, pretty wet behind the ears, and MassChallenge and the Health Policy Commission have really been essential partners for us sort of in our journey to date. So excited to be here, excited to share a bit more and hopefully some knowledge for folks in the crowd about how we can design more equitable and accessible products. So our mission, the basic premise here is substance use and mental health treatment system. It fails patients pretty fundamentally. So really the solution is to equip patients to engage with each other. When patients support each other, they act with more agency and see better outcomes. So I'll focus a bit on substance use just for the focus of this presentation, but our model is whole person. So we support across a broad range of chronic health conditions and mental health needs. Next slide, please. So looking at the problem, just a super quick overview, right? Because this is obviously a problem that could have its own multi-hour presentation, and there's many of those. We're spending over $45 billion a year on substance use treatment. It doubles every 6 years. Why did I start with the money? Because we're spending this much money and 90% of the people are not getting care, right? So obviously we're spending on the wrong kind of treatment. The other type of thing to really notice here is that it takes 8 years on average for someone from the first time they seek care for a substance use disorder to their first year in recovery. And that really means that we need to shift our framework from stigmatizing behaviors, from looking at days clean, to really looking at how do we support folks longitudinally, right? This is actually a chronic health condition, maybe closer to diabetes or COPD, where you really need to support folks in living the lives they want, right? As opposed to moralizing or stigmatizing different behaviors. Next slide, please. So this is a presentation about disparities, right? And the point here really is that everyone is aware of the opioid crisis, I'm sure, in this audience. The example here is really that we have put so much interest, so much money, so much going into awareness and expanding access to care. And that has just ended up with such poor and uneven results, really, in some ways. So buprenorphine is one way. It's a medication that can be delivered in an outpatient setting. It's a very cost-effective, very evidence-based way to treat opioid use disorder. And there's been tremendous policy interest over the past, I'd say, 5 years in terms of increasing access, the number of providers, the types of care settings where bup can be delivered. It's quite significant. You'll see there's a 2-3x gain in just the number of providers that are offering this service. But then, right, you look at the actual disparities, and it's a white population is 35 times more likely to have a bup visit than Black Americans, right? So that's just one way to look at it. But 35x, right, that really tells us that it's not necessarily just access to treatment, right? Oftentimes it has to do with the relationship people have with the system itself. Next slide, please. So we are a virtual provider of peer support. What that means is we layer one-to-one coaching from a certified peer specialist or recovery coach. So someone who's had a substance use or mental health condition themselves has then received training in terms of how to support others, with basically a 24/7 online community that has the goal of expanding the reach of treatment beyond the clinic. So what do we mean by that? Well, say you're in outpatient medication-assisted treatment, so your prescriber, your PCP is giving you buprenorphine. You might see that prescriber, once a month. They're going to check on you and sort of write you a prescription for the next month. Of course, if you have a substance use condition, right, you live that every day. So what we're really trying to do is change the fact that 60% of the people who start MAT don't make it to day 60. Right, and the issue is really that nothing is really sort of right supporting folks in between these sort of discrete appointments. So what we do is we start everyone off with sort of a one-to-one phone call with a peer that sort of orients them to our service, orients them to the sort of whole person wellness planning that we do, which basically means when we talk to someone, we try to understand what is most important to you in your own recovery. Right. So, for example, people oftentimes have goals around getting a job or getting a girlfriend or moving to a nicer house. And we really try to focus our support along those types of needs. But after that one-to-one call, folks have access to our 24/7 network of different text-based support groups, our mobile app that has various support groups as well. And they might not ever again interact with the peer who did their onboarding phone call because they can talk with patients and other peers across all of our sites nationally. And then finally, sort of in the end here, you can actually see that we do different text-based role plays and different skills-based sort of modules that allow our patients to actually pick up peer skills themselves and then take a more active role in moderating groups and supporting others as they join the platform. Next slide, please. So really the value that we play within the healthcare system is that we are an intervention, we are a support network that has a very, very low bar, low friction to engage with. Right? If you want to get, say, buprenorphine, you need to be seen by a doctor. You need to stop using drugs long enough that you start feeling sick, and then you need to get a prescription, right, and do an induction. Whereas texting into a support group, right, is a lot lower friction. So we engage a lot of folks who maybe are not yet ready to stop using substances, but are at the point where they're actually reaching out for help. So for example, here we have Queen of Clubs. I'm hoping to be able to share with women who've been in my situation. Single mothers, people who suffered from domestic violence are very common members of our platform. Oftentimes because they don't feel safe going to 12 steps or AA groups. And then the other really big component of our model is what makes it sustainable is that the members support each other. So right here we have Night Owl. I have to leave for a little while, but I'll be back tonight probably at about 2 a.m. And the point here is we're basically giving someone like Night Owl who wants to sort of reinvest in the recovery community that sort of made him healthier, offering to support other members, and we're able to cover right at a time like 2 a.m., right, which is a normal program. There's no way you could staff 2 a.m. 24/7. Next slide, please. So the whole thing is built on a natural language processing, a sentiment analysis, sort of AI engine we designed. And the goal here is really to understand that someone is so much more than claims data, right? Someone is a much sort of broader set of sort of goals, needs, et cetera. So what we do with this technology is when folks are messaging in our platform, we try to identify, right, different social, medical, or behavioral needs that folks are mentioning. And then we basically use that to engage the individual with different interventions. So for example, when somebody's messaging in here, we got this person who's flagged from claims data as having opioid use disorder. When they start talking in our group chat, suddenly they're not even mentioning the opioids, but they are talking about, hey, I'm actually thinking of stopping my alcohol use. It's affecting my depression. And I don't have access to great housing right now or recovery supportive housing. So it's the type of thing then when we detect these needs, we can then send that patient a response and say something like, okay, here's an SMS-based sort of check-in around alcohol use or around any of these other needs. And the reason we do this is to preserve fidelity to the peer model, because this way our peers can focus on engaging people one-to-one and don't have to focus right on documenting all these different clinical and social needs. Next slide, please. So this is my last slide. I'll just end here. We are active. So we primarily work with within the Medicaid space. We're active in a couple states right now, but just so you get a perspective of really how the system works in practice, what we're doing is we're engaging patients with this service so that they're more likely to be retained in outpatient and primary care. So we're a layer, right, that really enables the work of primary care providers, which are really right the center of sort of proactive healthcare. So in our first study that we actually ran with some collaborators at Brown, we retained 81% of 50 patients at over 7 weeks. So that's best in class, right? Most people don't finish even 45 days of MAT. So we actually plug our system into a sort of set of email and web-based alerts that will actually send PCPs and other care teams notifications when sort of clinically relevant or concerning things come up within groups, and then we coordinate that way. So I'll stop there. Would love to take some questions, and hopefully I can be useful to folks here. Thank you, Chelsea. I think it's pretty good too.
It's excellent. Thank you, Shrenik. Can you talk about just how you got started? What led you to do Marigold and helped you understand the opportunity here?
Yeah, of course. So I think like some of the other panelists, I was part of the population we were trying to serve. So there was a significant element to which my co-founders and I, felt that there were cultural reasons that we ourselves couldn't access this type of support. But personally, what kind of drove me to start a startup was my first job was I was a firefighter EMT. I ended up running a lot of overdoses, a lot of suicide attempts. And I mean, really what was kind of heartbreaking was there were folks who I'd basically run, week after week, I'd basically be called to the same person's home for an overdose. You'd get to know these people really well, right? Like by the third or fourth call, you pretty much know, my first name basis, their family. And then some of those people, they didn't end up living. They ended up dying from overdoses. And it was just really, quite dystopian to see that here I was as an EMT, seeing this person once a week. And if they had been seeing, right, a therapist or some type of actual, right, behavioral intervention during that time period, they would probably still be alive. So that was a significant motivating factor. So I dropped out of my undergrad with my co-founders at Hopkins to start this company in 2017. Good for you.
Can you tell us about the resources in terms of information, research, improving the concept that have been most useful to you as folks identify areas they want to invest their time in? Where should they look?
Yeah, so I think for us, what we were really saying is there's this great evidence-based intervention, which is peer support. Everybody knows it's engaging, right? Folks have seen sort of the reach of AA and 12 steps, and people have seen sort of one-to-one peer coaching programs be successful. The traditional challenge with peer support has been, how do you preserve the relatability of peer support while the relatability and the non-hierarchical nature of peer support and tie it back to the rest of the care team somehow? Because you have issues with AA and NA meetings where drug dealers, for example, will show up in the parking lots, right? There's an issue in terms of actual oversight, and that sort of makes that community totally siloed from the rest of the care team. So we were really just making the case that here we have this solution that will basically take the engagement that's currently happening, on Reddit, on sort of random online forums. We'll just create a bit more structure and give folks a place that they could go to basically get the same engagement. So essentially we were saying people were already getting this support, and now we're basically giving them a better experience that adds value to other healthcare providers.
Thank you. Yep. And then last question before we move to our next speaker and presenter. How are you growing the platform? Where are you finding folks to join? Are they, scaling out?
Yeah, so we contract primarily with managed Medicaid plans, though we also are now working with some commercial groups and health systems. Basically, we find an anchor partner in a market. We usually get a relatively high rate per engaged member per month for folks that have moderate to severe needs. And then those members subsidize the rest of the community. So we don't expect to actually be billing for most of the people on our platform. We try to engage a certain number of folks who are, just being discharged from inpatient programs. But then we'll have our peers basically go out into the community, find who are the folks who are looking to sponsor others, find who are the folks who are active in the local recovery community, and then we'll bring them into the social network like you'd bring them into really other networks. The way we sort of handle sort of staffing is we have a locally based full-time peer in each market we go into, but then the actual support is distributed. So, right, that one person will form referral partnerships. They'll basically, sort of educate us in terms of the needs on the ground. But once someone's in the system, they might find that they'd rather engage, with our peer in Delaware or with our peer in Maryland because they have a lived experience that matches theirs.
Sure. Yeah, I'm glad you mentioned social network because it strikes me that it has like a certain resemblance to it, and then the reinforcing effect of being able to find someone who you can communicate with and relate with and get support from. Thank you. Appreciate you being here and taking the time and sharing.
Thank you.
Next, we have Leo from Woolomi. So excited to have you here, Leo. Ready for you to present whenever you are.
Thank you very much for the time today. And I am so grateful to be here, and happy Black Maternal Health Week to all the Black moms out there. Yes. So next slide, please. So Woolomi, we are actually on our phase 2 of reinventing our community, and based on a lot of lessons learned that we've had on our first beta. Next slide, please. So Woolomi is a community that is built by a clinical woman of color for women of color to help women on their journey during pregnancy to enjoy the pregnancy and also navigate the health system for better outcomes. Next, please. So what are a lot of the problems? I'm sure a lot of us have heard that Black women are 3 to 4 times likely to die during pregnancy or due to pregnancy complications than white women. And a lot of this problem is they're not problems that cannot be, that are not preventable, right? A lot of them are problems that we can easily prevent in the healthcare system. And one of the things that moms always say is that they feel that they're not being listened to, they feel neglected. And oftentimes when they're given information, they're given information way too late. Next slide, please. And so what is the solution that we have? We have a solution that puts the mom at the center of their care, where they feel they can own the journey, own their pregnancy and motherhood journey, and connect them with clinically sound information so that when they're going through their pregnancy journey and motherhood journey, they have the information they need to pretty much advocate for themselves and know what to expect with the healthcare system. And so we also believe in creating this community around moms who are like-minded, so that everyone can share information on how to better ourselves in the healthcare system. Next. And what does that feature really look like for us? It includes having the mom have the ability to actually talk to experts, healthcare experts, in a very informal way. Like a lot of my colleagues have talked about, we also have mental health experts who we believe are culturally competent. We have simple things like dermatologists who are culturally competent, and all the other experts that we know that moms would need on their journey that oftentimes are hard to talk to, or we also know that those 20 minutes appointments are not enough. And so we have those experts in an informal way for moms to talk to them. And we've talked about the community, just being around moms, similar moms who are going through the same journey, often exudes joy in the pregnancy journey, in the motherhood journey. And also we have the weekly updates, which includes a lot of clinically, a lot of culturally competent things that really speaks to the pain points of women of color, especially Black moms, during their weekly pregnancy journey. And then we also have mental health screening. A lot of the important aspects of the pregnancy journey and the motherhood journey is mental health, making sure that our moms are in good health, have the support they need, and that we easily can address and identify when moms are not doing so good, and when it's just beyond the early pregnancy or postpartum fatigue. So our ability to quickly identify those things in the community and be able to connect moms to resources is very important and crucial to the mom and to the baby. Next, please. It takes a village to raise a child, and that's really what we are all about. We are of your virtual community that is moderated by a clinical, by a nurse, for us to have better outcomes and navigate the healthcare system. Next. And that's pretty much it for the presentation. You could always find me at these places.
Thank you, Leo. Can you describe health equity and how you got started with Willomi?
Yeah, health equity for me in the most simplest form is basically the ability to go into the healthcare system and be treated like an average white woman. I think that's as basic as I could say it. It's basically when I go into a healthcare system, me or any other Black mom, ability to be able to have providers see us and treat us equally as they would, and take our symptoms and signs and symptoms as complaints, and they would take it as seriously as they would any like average a white woman. And that's simply what equity means to me in this space. That said, how I started this, my mom was actually, she was actually a midwife, and I used to love the community aspect of birthing. And when I was growing up, I said, okay, I'm gonna work in the, I was going to become a midwife myself, but I realized that was not the thing for me. But one thing that I realized is I wanted to be I wanted to be in an environment where there's joy. But I quickly realized as a nurse in the United States that joy, you don't always have joy when you're having a child. Sometimes it ends tragically. And I started to learn from the different places that I worked that the kind of treatment that you get is really different depending on the demographics of the hospital system. And so as a nurse, when I started to, when it was time for me to have my child, I decided, okay, I wanted to create a journey for myself that I know will give me the best outcome, knowing what I know about the healthcare system. And once I did that, I really realized that I didn't want to keep that to myself. I wanted to share my journey and share what moms like me can how they can navigate the healthcare system, because I've been blessed to be a registered nurse and somebody who has a degree in healthcare administration. So,
Well, with each of the businesses we've heard from today, and yours especially, it strikes me, how plain, I guess, the issues are, how obvious they seem to be. and that it's taken this long, I guess, to address them, but that, it's time to share. And I think I've recognized in each of our speakers today that sense of, well, this is, as we're talking about, just inequality, and we have a solution and an ability, and we can fix it. So I appreciate you all taking the initiative really to do that for many of our benefit. Could you talk about some of the assumptions that founders should avoid, and some of the questions they should be asking themselves as they're building their businesses?
Yes, I definitely thank you for that question. Even as a Black woman myself, when I was starting this, I really thought I had the answer, and from a clinical perspective, and I had to find out that some of the assumptions that I had were not right, and we would not get our moms to come to the table, because as we know, healthcare, I always say, is not sexy. So when we are thinking of building things for especially women of color, especially Black mom, we need to, or Black women in general, we need to make sure that we're not coming, we have an open mind, and that we are speaking we have the representation to really understand the community. And that's one of the things that even I had to do, and start to ask questions of the moms and get answers. And another thing that I believe is very important is to always look at the data. Like a lot of a lot of us as startups, we start to mine our data, right? And oftentimes, if you believe that equity, especially with Black women, is something that is important to you, or to any demographics that you're interested in, I strongly suggest that you start to look at the data and make sure that you're curious about it and see, how is my product or what I'm doing, how is it doing with this particular population? And I think that's one of the mistakes that was made a lot of times in the healthcare system, where we were just delivering care and we weren't even looking at racial specific data until very, very recently. And so don't make the mistakes that the healthcare system made. And now they're like trying to correct itself, and now look at very recently, look at how do we create racial specific data that we're looking at, making sure that our providers are looking at them. We have to make sure that as we create this the product, that we're truly looking at the data and making sure that our product is delivering what we want it to deliver, right?
Right.
If you want it to reach a certain group and you feel like, okay, why am I not reaching those groups? Look at the data and talk to the specific groups.
Sure.
Representation matters.
Absolutely. Thank you. So I'd like to bring all of our panelists and guests back for a last round of questions to get each of your feedback on. Feel free, we'll do our best to manage it virtually just so that folks aren't talking over each other, but I don't imagine that being too much of a concern here. So for whoever would like to go first, in your opinion, what would need to happen to make an equitable healthcare system? Structurally, give us a broader overview of some of the changes that really need to be made. And maybe Shrenik, we'll start with you.
Sure. I mean, there's a lot of changes I think that need to be made, but perhaps I'll frame it in terms of things that, our company and potentially founders could do. Something that comes to mind is there's actually a law that was passed during the 2008 financial crisis on the heels of it, called the Mental Health Parity and Addictions Act. And it basically maintains that if you're an insurance provider, you need to offer equal sort of behavioral health benefits, right, alongside whatever you're spending on physical health or medical health. The problem is, like, this law, while it's written into law and there's sort of government agencies that go after payers that don't follow the rules, it's sort of like broadly not enforced. So I think a lot of it is sort of educating folks a degree to which, like, they actually do have like entitlement to certain coverage, certain resources, certain care under Medicaid, organizing them to then sort of advocate for that. And then on the more practical level, with the managed care organizations, they oftentimes will complain that they have no way of reaching these people. So having them on a platform, basically, right, like advocating for what they actually see as the care they need, will oftentimes put a sort of very compelling case before them that they really can't say no, right, to offering those additional resources. So that's, like, in our space, something that comes to mind in particular, parity, and really just reminding folks that oftentimes, like, they're getting a very sort of subpar service that's actually illegal, and they're just not aware that that's the case.
Wow. Yeah. Rodney, Anastasia, Leo, is that true in your perspective, Rodney?
Absolutely. Forgive my phone ringing in the background. I just turned it off. Yeah, absolutely. In terms of access and health equity, I think that there needs to be a seismic shift in the way we, as consumers of healthcare and providers of healthcare, understand that there are populations that historically have just been left out of the healthcare system, and Medicaid, particularly being the largest payer of healthcare services in America, needs to be recognized, and entrepreneurs and founders and funders need to understand that that's the market and that's the population that needs to be served. It's not very hard to do. It's just a real embracement of the terms inclusion and acceptance.
Sorry, I was trying to answer a question on the chat, and it's a bit tricky. I think for us, there are two sets. There's two sets. So in general, I feel like there's an apprehension with Black women, and they are, if they could go anywhere but the healthcare system, they will, right? So, and that's where a lot of that's where the opportunity lies, how to bridge that gap, because as for example, Wallami does not want, we want women to make the decision if you want to have your baby at home or whatever, however you want to safely do it. But at the same time, there are cases where you do need to be at the healthcare system. So being able to feel safe with the healthcare system is one of the most important things for us as far as outreach goes. Yeah, I think that's what, I hope I answered your question. Sorry.
Yeah, I think it really is a sense of being able to advocate for yourself and understanding what's behind you to advocate for, right? Like there's the legislation, there's my own personal empowerment, and having the confidence to speak to a provider or insurer with that knowledge. We'll have one last question for the group. And what are some of the practical, if each of you could offer one, and Anastasia, we'll start with you. What are some of the practical takeaways and advice you could give other folks here? This, seems to come up a lot, right? I want to get to where you are, and with a similar idea or in a similar space. What advice would you give me?
Oh, it's very complicated question, but a very important one. Because we have to deal with very small group of people actually, but what we actually got noticed during years of our work, that it should be the work both of society and companies and entrepreneurs. I mean, they should move to each other, and of course, it's very, very big. A big extent it's work for profile organizations. I mean, which work for supporting these or another category of people to implement more interaction with businesses, with organizations, with societies, communities, and so on. To share the information, to popularize information, how to work with people with special needs, and of course to implement more practices, and availability of services for everyone should be top of priority for any organization and business. So I think that's what I can say there.
Thank you. Rodney?
Yes.
What advice would you give someone starting with a similar idea, looking to get to, given your experience where you are now, if I'm starting a business in a similar space, working in health and equity, what advice would you give me? What takeaway do you have?
Stay true to your convictions. You have to, in order to do this successfully, you have to believe in what you're doing. The commitment to the process is not to make money. The commitment to the process is to change healthcare delivery in America. And if you believe in that, you'll fight through the difficult times. And hopefully at the end of that tunnel, there'll be some light. But my advice to anyone starting out today is just have a goal, have a commitment, have a true purpose, and just stick to it.
Thank you. Leo and then Shrenik.
Yeah, I would say that, yeah, I definitely second that. And I think for me is making sure that you are connected to the people. If you're dealing with Black moms or moms, you're connected to them. I think that's one of the reasons why a lot of time I try to be on the app, or like, because oftentimes I am just stuck in the nitty-gritty of things, and that doesn't bring me any kind of satisfaction. But hearing the moms, hearing their journey, hearing their birth stories, especially the ones that have started with us very early on, hearing their journey, hearing their story really keeps me going. And you need those things because it's tough, like it's tough, and please do not run yourself ragged like I'm doing. Trying to find support early and find money early.
Sure. Great advice. Thank you. Shrenik?
Probably some practical advice would be learn to code switch. The kind of nature of this work is that you will need to articulate your work and your value to a set of different stakeholders. And if you're not going through the exercise of how do I say this in somebody else's language, it's very easy to just like lean into your own biases and kind of like fall in love with your own solution. I think it applies at multiple levels. So like one level is at the policy level, right? Like most states, for example, are doing something around opioids right now. Do we need to position what we're doing as recovery coaching, or is it sort of support to prevent people from leaving the ERs? Is it a quality initiative? So speaking that language is important. When we're talking to our members, and this is something that's kind of specific to us because we do a lot of business in Medicaid, but we're not exclusively a Medicaid product. We don't ever want to say that we're targeting marginalized and underserved people, like in many settings when you're directly interacting with patients, right? Like we serve people with substance use disorders and mental health conditions, and we're partners with them in their recovery. You sometimes, right, kind of need to recognize that you're not always talking about the disparities, right? Oftentimes you're talking about directly serving someone, and you don't necessarily always need to index that on the fact that they're part of a marginalized population. So just understanding your audience, because you're always being true to your convictions. Like I think after 2 years in this space, you'll realize, oh, I really believe in this because I'm like putting up with a lot to do this work. So it's really just like, it's kind of up to you to come up with the new language, right? To communicate this to folks, especially who don't have a background in the healthcare policy space.
Yeah, absolutely. Well, thank you all for your time today, joining as our panel, for your insights. I really appreciate it. I know how beneficial it was to our group. We're going to leave it here. I thank all of our guests and attendees for joining and taking the time. We'll send out a follow-up survey shortly and updates on our next event. Thank you all. Take care.